Me what? I'm Dr. T. Arun, working in Emmanuel Russell College of Pharmacy as assistant professor. In today's session, we'll see about the topic in Unit 2, anticholinergic drugs. We'll see what is muscarinic receptor antagonist and we'll see some introduction and some basic things and we'll start with the topics. So we'll go through what is atropinic and what is parasympatholytic and what is hyperpolarization, depolarization, repolarization and some terminology and definition that will be more relevant to this topic and what is cholinergic neurotransmission and this will be the basic which will be more helpful for your understanding and have just highlighted in red which is completely for your syllabus oriented topics that will be included introduction and the MOA especially in heart and the pharmacology of anticholinergic drugs and indication and side effect and toxicity and its interaction. And what is atropinic? Atropinic is something that blocks acetylcholine at muscarinic receptors. And what does atropinic action do? It inhibits parasympathetic activity, so you get effects opposite to rest and digest, such as pupil dilation and increased heart rate and decreased salivation and decreased secretion in bronchial and gastric and urinary retention and CNS effect, just confusion in high doses, which can cause so on. And what is parasympatholytics? It means a drugs that inhibits the parasympathetic nervous system mechanism. Normally, acetylcholine binds to muscarinic receptors and gives parasympathetic effect, that is rest and digest effect. And this parasympatholytics like atropine, it blocks the receptor and there is no acetylcholine action, and because of no acetylcholine action there won't be parasympathetic action. That's why we are we are termed as anticholinergic drugs as parasympatholytics. And in this image we can see various muscarinic receptors and their subtypes and location and some abbreviation. Just please uh, go through on this image. I'll try to explain it. An M1 receptor, it's a G protein coupling receptors, and the messenger pathway is increasing PLZ, which activates IP3 and DHG, and which increases calcium, and the main effect is H3, and the M2 is the GI, which decreases adenyl cyclase and decreases cyclic CAMP and opens potassium channels and increases potassium flux, and the main effect is inhibitory. And M3 is a GQ, which increases PLZ and increases IP3 and the calcium is increased, and the main effect is H3. And M4 is GI, and which decreases the adenyl cyclase and decreases cyclic AMP and opens potassium channels and increases potassium efflux, and the main effect is inhibitory. And M5, it's a GQ, and it increases PLZ and increases IP3 and DHG and increases calcium, and the main effect is H3. So, for your understanding, you have to remember that GQ is excitatory and GI is inhibitory. And we'll see the location of muscarinic receptors subtypes. M1 receptors, it is basically in CNS, and M2 and M1 is in GI tract, which increases the motility and increases the secretion, and M2, it's in heart. SC node, AV node, the main action is decreasing heart rate, decreasing AV conduction, and decreasing conductivity. And M3, bronchial smooth muscles, and GI tract and GI tract, and in urinary bladder, and in eyes. So, so, so people who are watching this video, please make sure that you just understand the location of muscarinic receptors and subtypes, and and the muscarinic receptors main effects, so you will be able to understand the mechanism of action in an easy way. And the receptor dependent effect of acetylcholine. At nicotinic receptors, it causes depolarization. Mechanism: acetylcholine opens the sodium and potassium channel, and sodium enters, and membrane becomes less negative and results excitation. That's depolarization. And at muscarinic receptors, of the depends on the subtype. In M1, M3, and M5, it causes depolarization, and in M2, M4, it causes hyperpolarization. And what is depolarization? Depolarization is a process in which the membrane potential becomes less negative than the resting value. So in this image, you can easily make sure what is depolarization by closely watching this image, where we can see in first image there is less potassium, less sodium, and in second image you can see more sodium entering into the cells and becoming then the action potential is getting more positive, so it can cause depolarization. More positive charge, and the simple thing is it can cause depolarization. And what exactly happens? At rest, neuron is around minus 70 MB. A stimulus reaches the threshold, becomes, and the voltage gated sodium channel opens, and sodium rushes into the cells. Membrane potential rises, may reach to plus 30 MV. This is the rising phase of the action potential. Depolarization is a change in membrane potential from a negative value towards a positive value due to influx of sodium ions through a voltage gated sodium channel. And what is hyperpolarization? Hyperpolarization is when the membrane potential becomes more negative than the normal resting value. And here in hyperpolarization, potassium ion moves out. It moves out, and chloride ions moves inside. This makes the cells more negative. So membrane potential may go to minus 80 or minus 90 MB. So the charge of the cells are decreased, which causes hyperpolarization. And what is repolarization? Repolarization is the process by which the membrane potential returns back to its normal negative resting level. Here, the sodium channel closes, inactivate, and the potassium channel opens, and the potassium moves out of the cell surface. Inside becomes negative ion. And let's see what is cholinergic neurotransmission and nicotinic muscarinic pathway and drug action. And in this image, you can see the two neurons, and we'll just explain it. In the nicotinic receptor, the first neuron releases acetylcholine, and acetyl binds to the nicotinic receptor on the next neuron. This causes opening of sodium potassium channel, and which causes depolarization. And in the lower part, the muscarinic receptors, the second neuron releases acetylcholine, and acetyl binds to the muscarinic receptors. in organs such as heart, glands, smooth muscles. These receptors are G protein coupled receptors, and actions of now we are just coming to the topics. Action of tropin alkaloids like atropine, scopolamine. This blocks the muscarinic receptors, and there won't be an ACH. So acetylcholine cannot bind. So you can clearly see in this image the muscarinic receptors are in the organs. Okay, when the neuron releases the acetylcholine, it binds to the muscarinic receptors in M1, M3, M5, M2, M4. So we are closely going to the topic. We can see some tropin alkaloids such as atropine. They just won't allow the tropin to bind to the they won't allow the acetylcholine to bind to the muscarinic receptors. So atropine bind to the muscarinic receptors. It's like a competitive inhibition. So the acetylcholine cannot bind to the muscarinic receptors and cannot cause the activity of acetylcholine. So this is the basic thing. So there won't be any action on the muscarinic receptors. So it just gives the opposition of parasympathetic nervous system. So it causes parasympatholytics. So we all know that when acetylcholine binds to the M2 receptors in heart, can cause it can gives decrease heart. It can cause decreasing the heart rate. So when there is no binding of acetylcholine in the heart, okay. In coming week we'll see more about the anticholinergic system. So remember, drugs like atropine do not block nicotinic receptors, only blocks muscarinic receptors. So ganglionic transmission not affected, organ response blocked. So atropine is a selective muscarinic antagonist. Any nicotinic inhibition is only seen at subtherapeutic experimental concentration and has no clinical significance. And so you'll see some terminology and definition that is relevant to our topic. And what is vestibular activity? Refers to signals from the inner ear balance system that detects movements and position. And what does decreased vestibular activity means? It means the reducing the signals comes from the vestibular apparatus to the brain. Why is it important? Decreasing vestibular activity helps in conditions like motion signals, vertigo, nausea, and vomiting. And vagal action. What is vagal action? The vagus nerve is a part of parasympathetic system. It releases acetylcholine on the heart and acetylcholine act on M2 receptors. So slow heart rate bradycardia. What does blocking the blocks the vagal action means? It means inhibiting the effect of vagus nerves on the heart. So we can see the images and what is delirium? An acute reversible disturbance of consciousness and cognition characterized by confusion, disorientation, and impaired attention. And what is hallucination? Perceptions of something, seeing, hearing, and feeling without any real. And tremors, reduction in voluntary rhythmic shaking movements of muscles, external stimulus. These are all some the things you need to know about this topic, which will help you to understand in a good way. So you can easily understand what is anticholinergic systems, and we have seen the cholinergic transmission, and we have seen the subtypes and location of muscarinic receptors, and where it is and how it works, and we have seen what is uh, GI, GQ, what is depolarization, what is hyperpolarization, and so we have now we have some idea that will help you to understand the topic that we are going to see now. So this is the introduction of the anticholinergic system. Anticholinergic drugs are a class of medication that completely inhibit the action of acetylcholine at muscarinic receptors in the parasympathetic nervous systems. They are also known as anti-muscarinic agents or parasympatholytics. By blocking muscarinic receptors, these drugs reduces or abolish parasympathetic effects on various organs such as heart, smooth muscles, and the exocrine gland. However, they do not affect nicotinic receptors, which are present at the neuromuscular junction and autonomic ganglia. As a result, anticholinergic drugs produce effects such as tachycardia, mydriasis, that is pupil dilation, and bronchodilation, decreased glandular secretion, and reduced gastrointestinal motility. And the classification of anticholinergic drugs. So, in the classification, natural alkaloids, atropine, iosine, and semisynthetic derivatives, atropine methonitrate, homatropine, and hyoscine butyl bromide, protropine bromide, tiotropium bromide, and then quaternary compounds, propanthyline, siphenonium, ridinium, and glycopyrrolate, and in synthetic compounds, uh, Midriatrix, we have tropicamide, cyclopentolate, and vesicoselective, we have oxybutynin and sulfonacin, terifenacin, and flufoxate, and an anti-Parkinsonian, we have trihexyphenidyl and etc. And in anti-secretory and antispasmodics, we have tertiary amine and quaternary compounds. In tertiary amines, we have dicyclomine, and in quaternary compounds, glycopyrrolate, and pallidinium, isopropamide, etc. etc. So, in at some point of view, they can ask. We have questions like uh, classify anticholinergic drugs. So this will be more helpful for your at some point of view also. So the mechanism of action of atropine. Atropine is a competitive antagonist of muscarinic acetylcholine receptor. In normal condition, without atropine, acetylcholine binds to muscarinic receptors in M1, M2, M3, M4, M5. This causes parasympathetic effects. Normally, we know the parasympathetic effects such as rest and parasympathetic effects of rest and digest. So it's decreasing. So decreasing heart rate and increasing secretion in M3. And what happens after atropine administration? So atropine competitively binds to the muscarinic receptors. So you can see the in normal condition acetylcholine binds to the muscarinic receptors. When we give anticholinergic drugs such as atropine, it binds to the muscarinic receptors, and by binding to the muscarinic receptors, acetylcholine couldn't bind to the muscarinic receptors, and it fails to produce the parasympathetic effects. So when it fails to produce the parasympathetic effects, we give the after atropine administration, we give we get the effects that is opposite to the parasympathetic effects such as parasympatholytic effects. So it is just opposing the effects. So it prevents the acetylcholine from binding and no activation of parasympathetic response. And some you have to important concept that you have to be remember is atropine does not reduces acetylcholine release. It only blocks the receptor binding. So just remember on it, it is just blocking the muscarinic receptors. And in this image, you can see the atropine mechanism in the heart in M2 receptors. So where are M2 receptors? You have seen it previously in the image, so I'll explain it once again. M2 receptors are present in the SA node and AV node, and so normal physiology without atropine. Vagus nerve releases acetylcholine. Acetylcholine binds to M2 receptor in the SA node and AV node. M2 receptor is a GI protein coupled receptors. So we know GI means it's inhibitory. So GI inhibits adenyl cyclase and decreasing cyclic adenosine monophosphate, which finally causes increasing the potassium efflux and which causes hyperpolarization. This is the normal physiology without atropine. And what does after atropine in M2 receptors? What happens when atropine is added? So we can clearly see in this image. This is the vagus nerve, the green color, and we can see the M2 receptor. The red which is highlighted in as atropine. So when the atropine is binded to the muscarinic receptors, the acetylcholine which is released from the vagus nerves cannot bind to the muscarinic receptors. So it prevents the acetylcholine from binding to M2 receptors. M2 receptor is blocked and the GI protein is not activated. GI protein is not activated, so there is no inhibitory effect. And adenyl cyclase is more inhibited. So which causes increasing the cyclic AMP and increasing the calcium influx and decreasing the potassium efflux. And there is less hyperpolarization. So due to this, the heart rate is increasing. So increase SA node automatically and increase AV conduction and increasing the heart rate. And we'll see the pharmacological action in CNS. Atropine has a overall CNS stimulant action. However, these effects are not appreciable at low doses, which produces only peripheral effect because of restricted entry into the brain. The atropine stimulates many medullary centers, vagal, respiratory vasometers, and it depresses vestibular agitation and has anti-motion sickness property. The site of the action is not clear. Probably there is a cholinergic link in the vestibular pathway, or it may be exerted at the cortical level. By blocking the relative cholinergic overactivity in basal ganglia, it suppresses tremors and rigidity of Parkinsonism. And high doses cause cortical excitation, restlessness, disorientation, hallucination, and delirium, followed by respiratory depression and coma. And in CVS, we have already seen the um, atropine action in the heart. So the once again, the most prominent effect of atropine is tachycardia. So we can easily assume that whenever acetylcholine is not binding to the M2 receptor on hand, so it reverses, giving the opposite effect such as tachycardia. It is due to the blockade of M2 receptors on the SN node through which vagal tone decreases, right? And higher the setting vagal tone, more mark is the tachycardia. Only IM and subcutaneous injection transient initial bradycardia often occurs. Earlier believed to be due to stimulation of vagal centers, it is now thought to be caused by blockade of muscarinic autoreceptors on the vagal nerve, ending thereby augmenting acetylcholine release. And in eye, the autonomic control of iris muscles and the action of mydriatrics as well as myotics. Topical installation of atropine causes mydriasis. Uh, Abolition of light reflex and cycloplegia lasting 7 to 10 days result in photophobia and blurring of near vision, and the intraocular tension tends to rise, especially in narrow angle glaucoma. However, conventional systemic doses of atropine produces minor ocular effects. So you can see the image effect on eye of anticholinergic drugs. We can see in the normal people, and after anticholinergic action, you can see the pupils are dilated, and smooth muscles or muscle smooth muscles then receives parasympathetic motor innervation are relaxed by atropine due to M3 blockade. Tone and amplitude of contraction of stomach and intestines are reduced. The passage of time is slowed and constipation may occur. Spasm may be relieved, however, peristalsis is only incompletely suppressed because it is. And by seeing the image, you can also try to understand in a better way. And in glands, atropine markedly decreases at salivary, tracheobranchial, and lacrimal secretion. Skin and eye becomes dry. Talking and swallowing may be difficult. And atropine decreases secretion of acid, pepsin, and mucus in the stomach, but the primary action is on volume of secretion, so that pH of gastric content may be elevated unless diluted by food. And intestinal and pancreatic secretions are not significantly reduced. Bile production is not under cholinergic control, so not affected. And body temperature, a rise in body temperature occurs at high doses. It is due to the both inhibition of sweating as well as stimulation of temperature regulating centers in hypothalamus. Children are highly susceptible to atropinic fever. And pharmacokinetics, in absorption, rapidly absorbed from GIT and well absorbed after IM and IV, and rapidly penetrates cornea, and in distribution widely distributed in body tissues and can cross triple B, mainly the drugs which comes under tertiary amines, and crosses placenta and appears in breast milk. And isokin has greater CNS penetration than atropine. And metabolism, it's about 50% metabolized in liver. Rest of the dose remains unchanged. And in excretion, mainly by kidneys in urine, a significant portion of atropine is excreted and unchanged. And renal excretion influenced by urinary pH. And half-life, the half-life is approximately 3 to 4 hours. Effects may be long due to slow dissociation from receptors. And the indication, it is used in pre-anesthetic medication and can be used as used in bradycardia, and in ophthalmology, and in respiratory disorders, and in motion sickness, and gastrointestinal disorders, such as IBS, and and it is indicated in urinary disorders, and it is indicated in Parkinsonism as well as, and and it is used as an antidote in um, OPC poisoning as well as which reverse the sludge symptoms such as salivation, lacrimation, urination different, your etc. And we'll see the anticholinergic drugs and indication and basic mechanism of action of the particular indication. So atropine is indicated in pre-anesthetic medication. The mechanism of action: competitive antagonist at muscarinic receptors, which decreases the se- secretion in plants, and which inhibit the M2 receptor on heart and increases the heart rate. And the therapeutic effect: decreasing the salivary and pharyngeal secretion and prevents vagal reflex bradycardia. And we'll see the indication of bradycardia in bradycardia and the MOA and therapeutic effect related to the indication. So it blocks the M2 receptor in the SA node and AV node, removes vagal parasympathetic inhibition of heart in heart, increasing heart rate in symptomatic bradycardia. And in ophthalmology, blocks M3 receptor in the iris sphincter and the ciliary muscles, causes and the therapeutic effect: pupil dilation and cycloplegia, paralysis of accommodation for eye examination. And in respiratory disorder, it is indicated. Examples are hypertropium and iotropium, blocks M2 receptor in bronchial smooth muscles, and it causes bronchodilation and decreasing the bronchial secretion. And in motion sickness, it blocks hormone receptors in the vestibular nuclei and chromoreceptor trigersome, prevents nausea and vomiting. And gastrointestinal disorder, it is indicated such anticholinergic drugs or dicyclomine and the mechanism of action is blocks the M3 receptor on GA smooth muscles, which decreases the intestinal spasms and it lives and which have the relief in IBS as well as. And in urinary disorder, the examples of drugs are oxybutynin and the mechanism of action or blocks M3 receptor in the detrusor muscles of urinary bladder. Latches of the therapeutic effect relaxes detrusor muscles and treats overactive bladder. And in Parkinsonism, the drugs are trihexyphenidyl, and the mechanism of action blocks muscarinic activity in basal ganglia and reduces tremors, rigidity, and drug-induced extrapyramidal symptoms. And in um, antidotes in poisoning, such as it is mainly used in OPC poisoning, the drugs are atropine, reverse excess muscarinic stimulation in M1 to M5 blockade. The uses or therapeutic effects or it reverse the sludge symptoms. So you can see some images which will be more helpful to understanding the overall mechanism of action of anticholinergic drugs. And see the side effects of anticholinergic drugs. The common due to muscarinic blockade such as dry mouth and difficulty in swallowing and talking, and dry hot skin, flushing, and blood vision, photophobia, and tachycardia, palpitation, constipation, urinary retention, and reduced bronchial secretion. And toxicity occurs in overdose or belladonna injection, and peripheral features such as severe dry mouth, hot, dry, flushed skin, fever, urinary retention, and CNS effect, excitement, agitation, delirium, hallucination, ataxia, and severe toxicity hypertension, respiratory depression, and convulsion, and even coma. And the management of toxicity, gastric lavage, and cooling measure for fever, and some antidotes such as physostigmines, and supportive care such as respiration, BP, and diseases. And so in this, I have new statement. Just remember that it does not reserve CNS toxicity and drug interaction. Absorption slowed and absorption increased and absorption reduced even may occur. In absorption slowed, absorption of most drugs is slowed because atropine delays gastric ingestion, EMT. This results in slower absorption and greater peripheral degradation of levodopa and less of it reaches the brain. This does not occur when a peripheral decarbotylase inhibitors are combined and the absorption increased. On the other hand, extent of digoxin and tetracycline absorption may be increased due to longer transit time in the GIT because of delayed gastric emptying. And antacids also interfere with absorption of anticholinergics. Mm, and other drug interaction or antihistamines, tricyclic antidepressant, thiazines have anticholinergic property. Additive side effect may occur with atropinic drugs. Um, and Monoamine oxidase inhibitor interfere with metabolism of anticholinergic anti-Parkinson drugs, and so because of that, delirium may occur. So thank you all for being listening to this video. Hope you all understand the topic of what is anticholinergic drugs and what is parasympatholytics and what is atropinic effect, and we have seen the various subtypes of muscarinic receptors such as M1, M2, M5, and we have seen the mechanism of action of anticholinergic drugs. So hope you all understand what is anticholinergic drugs and how it really works, and where a lot where it is indicated. We all understand this topic. Thank you so much for watching. Thank you so much for watching this video. Thank you all.